So this is video 7 and we are on page 16. So what is regression analysis? So regression analysis. So what my understanding is that regression means in which it's a statistical technique which aims to model the relationship between multiple variables. In medicine, it is most often used to identify and control for the effect of possible confounding variable in an experiment. It is frequently applied in case series aiming to compare non-randomized cohorts. Occasionally, it is used in randomized trial if random chance has created an imbalance in key confounders. Regression analysis may also be used for prediction and is essential in the development of risk prediction models such as POSUM and VB-Home. So all these scoring systems, I think they use this regression analysis to develop a relationship between multiple variables. So what types of regression analysis do you know? Number one is linear regression, that both variables have a linear relationship. The dependent variables, so both variables on x and y axis, they are in continuous. Next is logistic regression. The dependent variables is categorical yes or no variable. If the data held on a blood loss in our vascular surgery cohort were simply recorded as more than 1 liter or less than 1 liter, so it's yes or no. So this is called logistic regression. And Cox regression, the influence of multiple variables on survival is evaluated. So on survival is Cox regression, and Cox regression is generally only used under the expert guidance of statistician. Next question is, what are the limitations of regression? So it's based upon assumptions about which variables should be entered at the start. Incorrect assumption will lead to flawed models. In surgical series, the models are often applied to small cohorts. The model then lacks sufficient power to tease out the relationship between the competing variables, which are erroneously determined to be independent of each other. And the last limitation is, as a rule of thumb, in order to construct an adequately powered model, there should be at least 10 patients with the outcome of interest for each of the candidate variables entered in the model. For example, if you read a report of a regression analysis of factors influencing the complications following colorectal surgery, 10 variables are entered into the model, but there were only 50 patients with a complication. The model is likely to be underpowered. Okay, so regression analysis is finished. Next is ROC curves. So I initially thought, what is ROC curve? Then I googled it, that ROC means it's a receiver operating curve. So like in regression analysis, it's the relationship between multiple variables. In ROC curves, this is used to look at the different diagnostic tests. So this is my understanding. So their receiver operating characteristics curves. The ROC curve is a graphical plot which illustrates the performance of a test. This is what I said. So ROC is a graphical plot which illustrates the performance of a test as its threshold of discrimination varies. The test must have a threshold value above which a positive result is returned and vice versa. The curve is generated by plotting the fraction of true positives out of all positives against the fraction of true positive out of all positives against the fraction of false positive out of negative as various. So y-axis and x-axis. So one has fraction of true positive out of all positive and one has the fraction of false positive out of all negatives. It is a trade-off between sensitivity and specificity. How do you interpret ROC curves? Again, rule of thumb. If ROC, there will be a central line, and towards the upside means it's a good test, towards the x-axis it's a bad test. The ROC curve is drawn based on the true positive rate and false positive rate. The best possible prediction method would have a sensitivity of 100% and a specificity of 100%. This would be plotted on the curve as a coordinate 0, 1, which would lie on the upper left corner of the ROC space. The better test is closer, it will lie to the upper left corner of the ROC space. So upper left corner of the ROC space is a good test. A test that is performing no better than random chance will yield a point along a diagonal line running from the bottom left to the top right of the ROC space. This is called the line of non-significance. So line of non-significance, top left good, line of non-significance down on the right, not a good test. What does the area under the curve mean? AUC, area under curve. The area under the ROC curve is summary statistic that is used to summarize the performance of a test at variable thresholds. A perfect test would have an area under curve of 1, but in reality this is never attained. A poorly performing test would have an area under curve of 0.5 or less. So 0.5 is the cutoff point, it's a very less. The area under curve is sometimes also referred to as the C statistics. In medicine, a test with a C statistics of 0.8 or greater is considered to have a good discrimination, like in power of study 80%. Value of 0.6 and 0.8 are considered to be indicate moderate discrimination, and anything below 0.6 is poorly discriminate. So let's finish these ROC curves, and then are the screening tests. Again, what is the screening? What do you know about the screening? So again, there are points. So screening is a population-based strategy which aims to identify disease before it's clinically obvious, thus allowing earlier and hopefully more effective treatment. The overall aim is to reduce the disease-related mortality. The screening tests differ from other tests in that they are generally performed in apparently healthy people. So what criteria need to be fulfilled to justify a screening test? A test must be available with reasonable sensitivity, to a good reasonable specificity, must be, or disease have a good cases in the population, or test is acceptable by the population. Test must carry minimal risks, and a test should be economically viable, and effective treatment must be available for the target disease of a screening exercise. What types of screening do you know? So broadly, there are two types: universal screening for every patient, and case selection and its particular case group of the people. Explain what is meant by sensitivity and specificity. We have discussed previously that sensitivity means inclusion positivity and specificity means exclusion negativity. Sensitivity provides a measure of proportion of the group with a condition that detects a positive. Clinical examination of the abdominal aorta aneurysm is positive in about 50% of the patient. So therefore, clinical examination has a 50% sensitivity. Okay. So sensitivity is calculated by dividing the number of true positives divided by the sum of the true positive plus the false negatives. So again, sensitivity is top with true positive divided by true positive plus false negative. And specificity is the measure of the ability of a test to correctly classify an individual as a disease-free. How it is calculated again, so all the patient with negative will be on the top and divided by the true negative plus false positives. So note that sensitivity does not take account of indeterminate test results, but sensitivity relates to the ability of test to detect positive results, and specificity relates to the ability of test to detect the negative results. What are the disadvantages of the screening? Sometimes it's over-treated. There is a risk of false positive. This may lead to unnecessary anxiety or treatment. There is a risk of false negative, that if they have a disease and their test fail to pick that up. Screening exposes large number of people to tests who ultimately do not require any form of treatment. And if the disease is detected in advanced incurable stage disease, the screening simply prolongs stress and anxiety without affecting the ultimate prognosis. Okay, so let's finish here.